Every January brings new resolutions, but in 2026, it will bring new bills too. The moment enhanced ACA subsidies expire, millions face sudden premium hikes, while Medicaid's paperwork maze grows. It won't make headlines. It will, until you open your mailbox and see what's changed. Who gets hurt first, and can you spot the trap before it costs you? The law that kept premiums lower for millions of Americans runs out on December 31st, 2025. That is the date the Enhanced Affordable Care Act premium tax credits expire, and with no extension in place, the 2026 coverage year reverts to the old rules. For many, this means the second lowest cost silver plan will once again cost up to 8.5% of household income, and anyone just above 400% of the federal poverty level loses eligibility for subsidies entirely. The result? Net premiums can double or triple overnight, especially for older adults or families in high-cost regions. Open enrollment for 2026 coverage begins November 1st and ends January 15th on the federal marketplace, but the pressure is immediate. Renewal notices and premium calculators reflect the new math as soon as the calendar turns, and the gap between what people expect to pay and what is actually owed becomes clear the moment those credits disappear. A family in Maine living on seasonal income sits down in January to review their new health insurance notice. Last year, their plan cost nothing out of pocket. This year, the envelope brings a surprise, a $5 monthly charge for the same coverage. The difference is not just the loss of enhanced subsidies. The difference is the paperwork and the rules that govern renewal. Because their income fluctuated and they did not actively re-verify during renewal season, the system defaulted to an auto-renewal. That triggered an administrative fee, small but stubborn, and now it is $60 a year they did not plan for. For families on tight budgets, even minor fees add up, especially when groceries and heating costs are already rising. A local health insurance navigator explains that they are seeing more people tripped up by little steps, one missed document, one unchecked box, and suddenly coverage gets more expensive or drops entirely. The process, not just the price, becomes the obstacle. Medicaid enrollees will face a new cycle of paperwork and verification starting in 2026, even before the full rollout of work requirements. For many adults, the process now includes proving at least 80 hours per month of work, job training, or other qualifying activities. States are expected to use automated payroll and benefit databases first, but when those records fall short, for example for gig workers or people with irregular jobs, manual proof is required. That means pay stubs, letters from employers, or affidavits, all submitted on a strict timeline. Every 6 months, enrollees above the poverty line must complete this process, doubling the frequency of eligibility checks compared to the past. A missed form or a document that does not match can trigger a loss of coverage, even for people who still qualify. Navigators and state workers brace for a surge in calls and appeals as the volume of redeterminations climbs and the risk of administrative error grows. The result is a system where staying covered depends as much on managing paperwork as on meeting income or work thresholds. For people who rely on Medicaid, the financial impact does not always wait for a policy memo or headline. It arrives in the form of new out-of-pocket expenses. Under the One Big Beautiful Bill Act, adults in Medicaid expansion groups earning above the poverty line will face cost sharing of up to $35 per visit. This change will not take effect until 2028, but the worry starts now. Chronic illness turns a single copay into a steady drain. Imagine someone managing diabetes or asthma. 4 appointments in a month could mean $140 out of pocket, not counting prescriptions or lab work. Primary care and mental health visits remain exempt, but most specialist and hospital services are not. For families already stretching every dollar, these charges add up quickly. The law caps total cost sharing at 5% of household income, but even that ceiling can feel high when budgets are tight. Providers anticipate more unpaid bills and delayed care as patients weigh the cost of each visit. Rural hospitals enter 2026 with a lifeline that comes with conditions. The new backfill fund, set to run through 2030, promises annual support to offset Medicaid cuts. But every dollar is tied to state benchmarks, like meeting work verification targets or capping provider taxes. For a hospital administrator in Nebraska, that means tough choices. If the state falls short on compliance, funding stalls, and services are the first to go. Obstetrics and gynecology units, emergency room hours, and specialty clinics face reduction or closure. The balance is fragile. Backfill money helps, but it does not erase the risk that one missed benchmark could mean fewer beds or longer drives for care. Federal analysts now estimate that as many as 17 million more people could be uninsured by the early 2030s, combining the effects of expiring subsidies, stricter Medicaid rules, and new administrative hurdles. Supporters of the law argue these changes will save trillions over the next decade, calling it necessary fiscal restraint and program integrity. Critics warn the numbers hide real consequences: millions losing coverage, rising unpaid hospital bills, and gaps in care for children, veterans, and people with disabilities. The debate isn't just about dollars, it is about who gets left out. For millions, coverage now depends on paperwork, timing, and luck. When policy shifts hit your mailbox, the gap between law and lived reality is measured in dollars and days. Stay ready.